the time when I have a specialist on, a medical specialist on, I'm asking on behalf of you. But to tell you the truth, I had a little hip pain myself this morning, but it all went away when I had the ice cream that the girls were just talking about. However, I think it's important that we know what happens when it doesn't go away and when we need hip replacement surgery. Dr. Michael Wilmink, I do so appreciate you coming down, particularly because you're talking about a new procedure. But why so many hip problems on the part of humanity in general anyway? Is this kind of a weak part of our system?
It's one of the parts of the body where it takes the most load, the most force. When you walk and you do high-impact activities, which we've had increasing amounts of over the last 20, 30 years with more sports, more activities, the hip just takes the brunt of the load.
Well, I just had the coach of the Rattlers on, professional football players, and all of the potential damage that they have. Do you see a lot more athletes in your specific area of specialty?
I do, and typically a lot of runners end up with hip problems, unfortunately, down the road after they've been running for 5, 10 miles, for many, many years.
But now you're saying that as opposed to the traditional system of hip replacement, now you've got something new. And I would like to know, first of all, what it is that you used to do, the way replacement used to be done, so we can compare.
Sure, absolutely. Traditionally, hip replacements have been done through the side. We place the patient on their side in the operating room, make an incision on the side of the hip, then go through the back of the hip. To do that, we'd have to divide the gluteus muscle, get into the hip, and we'd have to detach muscles, tendons to actually get in, do the surgery, and at the end, reattach them, and then get the patient up and get them going.
Boy, that's a lot of invasive surgery, and it sounds like a lot of rehab afterwards.
Yeah, typically, it is. We would get patients up out of the hospital in 3 or 4 days, get them home, walking right away, but typically it was more of a 3-month recovery course.
Wow. And now?
And now we've taken the lead from the French and the Belgium, actually. Those are the ones who first started doing this procedure. Now we go actually through the front of the hip, where we no longer cut any muscles or detach anything. We actually go through a muscle layer.
In fact, I think that we have the procedure that you can describe.
Sure.
As we watch exactly what goes on with the new hip replacement surgery. If you're planning this at all, please pay attention and make notes.
Absolutely. So we can see here that we've actually just gone between the two muscle layers here. And you can see the retractors are in place right now and actually just showing the hip capsule. So instead of actually detaching those muscles from the hip joint and reattaching at the end, we simply divide them in half, and then we're able to cut the hip capsule, which exposes the hip, and then we go about, we put the exact same prosthesis or components in that we have for the last 20 to 30 years, but through a different approach, which makes it easier on the body to tolerate. We've actually shown we've had less blood loss from this procedure, so there's a lower blood transfusion rate afterwards, and it leads, we believe, to a more natural hip because you're keeping more of the normal elements of the patient's own anatomy.
Does the procedure itself, by the way, take less time?
The procedure, I think when surgeons start learning it, it takes more time. Now my typical operative time is about 45 minutes to an hour to put a hip in.
Wow.
So you can see here that that's a drill that's gone into the hip here, and we're able to actually pull the hip out of joint. And what we'll see at that point is usually a nice, shiny cue ball. White cartilage is gone, and you're left with just bone. And that's typically what causes the pain. You have bone-on-bone arthritis.
And that's what you replace?
Correct. So you'll see here that we are able to dislocate the hip. We've exposed it. We'll go in with a saw, and we do make a smaller incision for the surgery, but we're able to see everything that we need to see, so we're not compromising our visualization by using a different approach. If anything, I think we get more feedback during the surgery because we use live x-ray during the procedure.
Absolutely stunning. So you take out the bone and replace it with what?
We replace it with titanium at this point. Titanium goes into the femur down below, and up above the socket also is replaced with titanium. And then the dealer's choice in hip replacement is what type of surface you have articulating in there. And that can be metal on metal, it can be ceramic and plastic, or metal and plastic. So you can see here we've reamed out into the pelvis bone there, and that cup gets hammered in there and actually gets hammered in pretty hard. And that's the first part of the procedure. And the second part of the procedure here is you can see we use a special table with a hook to actually expose the femur, and at this point we're going to actually, you can see the bone marrow, the red portion there, We're going to remove that with a series of broaches that will go in and clear the path for the final prosthesis.
Have you improved on God's work with the replacement? Is it better than the bone?
It replaces that bone, but it doesn't replace the biological elements of the bone marrow. But you have plenty of other bone marrow in the body that takes over for that.
But the titanium will last longer than the bone itself, won't it?
Correct. Oh, the titanium should last 20, 30 years.
What is the youngest person that you're aware of that's gotten this kind of procedure?
I've done a hip replacement on a 19-year-old.
So it might be reasonable then, if you're talking about a 30-year span for the titanium, it might be reasonable that he might have to have it done again sometime?
Correct, yes. So that's the lifespan. It has been 20 years. We're hoping with the newer bearing surfaces that we're going to get to 30, 35 years possibly.
Talk to us about this.
Yes, this is right here. I brought in an example of, this is the actual components that we put in. So
and if you hold that up, they'll be able to catch it.
Sure, absolutely. So you can see here, this is the titanium prosthesis that will go into the femur. It has a grit surface here that actually your bone, the patient's bone, will grow into. So it becomes a solid piece of you. And then on top of that, this is an example here of a ceramic head here, which will articulate with a polyethylene liner, which is a fancy name for Teflon. And the most recent version of this, which I use for my patients, has vitamin E in it.
Really?
Yeah, and what that does is it reduces the antioxidants in the material, which therefore will make it last longer.
Absolutely astounding. Every time I see one of these procedures that's continued to progress and move, science changes just like all technology. But has the cost improved? Is it more expensive now with this new procedure or less?
The costs involved, we use a table to do the procedure, but I think those costs are dissipated after probably about a year at your facility, because we send about a third of the patients home the next day, and patients go back to work usually about 2 weeks, 2 or 3 weeks to desk work.
As opposed to several months before.
Correct. So the actual cost of the procedure may have gone up, but I think the impact on overall society, it's gone down.
Clearly, all of those advantages, and if you want to talk to your doctor about whether you're a candidate, that's fine, but you can also tell him if he's not sure, well, then all he has to do is to talk to Dr. Wilming, and all of that is available. All the information is available, and a very warm welcome at Arizona Orthopedic Associates, too. You found out about this remarkable breakthrough on the McMahon Group. I hope you appreciate it.